Well, folks, he's a first timer. He's a first timer, which is really always important. We always like first timers on Healthcare Unfiltered, but he is a world famous, renowned thoracic oncologist. Everybody knows the Haas. Haas, whenever anybody goes by a name of like MJ, Haas, you know that they have achieved, they've gotten somewhere. So first of all, welcome to Healthcare Unfiltered, my friend.
Thank you so much for the invitation. It's very kind of you. And I'm not sure I'm world renowned, but I appreciate the
Oh,
comment.
no, you are. So, I mean, like I said, you're the Haas. How did that happen? What got you into thoracic oncology anyway? And who are you?
I don't know how far you want to go. So my real name is Hossein Borghaei. When I was in medical school, I had a cardiology professor who thought on rounds saying Hossein took too long. He said, from this point on, you're Haas. And the name stuck, and they called me Haas. It's funny because Marty Edelman, who's the department chair here, he hadn't met me before. And, at one of the meetings, somebody told him, oh, go talk to Haas. He knows about whatever question he had. And he said he was looking for somebody who was like 6'2" with a hat and boots on, thinking Haas. And then he saw me. So it was a surprise to him. So that's how the name Haas started. I was born in Iran. I immigrated to the US when I was about 17 years old, spent about a year or so in Germany. Hey, Tony. And then the reason I got
So
interested,
you speak German and Persian?
I do. My German has gotten a little bit rusty just because I haven't practiced as much. You know how it is with languages; you really do have to practice and listen and work on it. But yeah, I was fluent in German and a couple of other languages. Because honestly, when I was in Europe, I wasn't sure I was going to be able to come to the US. I didn't know if I was going to get a visa, that kind of stuff. So I studied a couple of different languages just trying to figure out where I was going to end up. But
And I see you picked very important languages that are really going to get you somewhere, the Persian language and the German language.
look, things were different, okay? All I have to say.
Well, welcome, Haas. I really appreciate. And then we also have another first timer who, Tony, we were just talking about quick intros. This is your first time on Healthcare Unfiltered, but you come to us from a different time zone. So I appreciate the fact that this is night where you are. Just quick intro. And how many languages do you speak? So far, Haas speaks 3. His English is a little bit broken, but we can manage.
Yeah.
Hi, thank you very much for this invitation. For me, it's a great honor to participate. It's true, this is my very first time. I'm very excited about that. And yes, it's late here. My kids are having dinner and it's time for them to go to bed. Tomorrow they have to go to school. But really, really happy to be here. So I speak Spanish basically, and then I try to speak in English, a little bit of French, and I like a little bit some languages, and I'm able to understand a little bit of Italian, Portuguese, not
Nice.
not Dutch, not German. I mean,
Yeah. Yeah.
I'm done.
I do speak a couple of Persian words, actually. I have friends here in Chicago where I am that have some Persian restaurants, really, really good. So I know Shab Khair, Khuda Hafiz, Haas, I can navigate a few things.
Absolutely, you can. I have no doubt about it. And Tony, great to see you as always.
Thank you,
So
Hal. Thank you.
we were all at ESMO in Madrid a couple of months ago, and we're taping this on December 5th, 2023. This is slated to air actually in January, so it will be 2024, just for context for listeners and viewers. And I want to do this like rapid fire type of thing with 2 world-renowned thoracic oncologists, because as I was telling Haas before we went on the air, when I looked at ESMO, there's a lot of data, thousands of abstracts. But the 2 diseases that struck me that there's so much about were bladder cancer and lung cancer. I did an episode on bladder cancer, and we're doing this on thoracic. I felt there's a lot of information that might be related to how we take care of people and patients. And the way I thought we'll structure this, we'll talk about early stage disease and then metastatic disease and locally advanced. So Haas, is there anything that struck you at ESMO 2023 about early stage disease, or Tony, whoever wants to take this first?
Oh, I would say only 5 abstracts or so. Some So the early stage disease, obviously, again, everybody knows has taken a whole new dimension with the introduction of immunotherapy in the neo-adjuvant and now perioperatively, so neo-adjuvant and adjuvant setting. So what we saw at Ward Long was a long-awaited results of the Checkmate 77 T study, which was presented by Dr. Cascone. And this is, again, another one of randomized perioperative studies where patients with early stage lung cancer, mostly stage 2-3s, before they go to surgery, received chemotherapy and immunotherapy in relation to surgery. And then the experimental arm continued with the nivolumab in this case, for a period of about 1 year, and the control arm was basically best supportive care. So these have become very popular. So what is the advantage and disadvantage as far as I'm concerned? We'll see what Tony thinks. You know, when we had the 816 study, it was just 3 cycles of chemo IO, you go to surgery, and if a patient had a complete pathologic response, that was great. We had retrospective data, other data from the old days, suggesting that patient was going to do well, but we were all kind of nervous and sort of left as to what to do with patients with less than a path CR. And then come all of these perioperative studies like AGEN, like 671 and now 77T, because you have the option of continuing another year of immunotherapy in the adjuvant setting. Now, there are advantages and disadvantages from my point of view. The major disadvantage is that we're going to be over-treating a whole bunch of patients who don't need immunotherapy for a whole year, who could potentially suffer side effects. I mean, these drugs have adverse events associated with it, and their survival would not have been impacted by a year of immunotherapy. On the other hand, I am sure there are patients who would continue to benefit from a year of immunotherapy, and hopefully the survivals would be even better. We need time. We need more of a follow-up to from all of these studies. Again, AGEN, Keynote 671, 77T, to try to figure out what happens to a patient population with path CR or less than a path CR with a year of immunotherapy. But I kind of feel that this approach gives the physicians and the clinicians an option of continuing the immunotherapy if somebody doesn't have as good of a response, hoping that we can get there. The major crux of all of this is that these studies and the treatment of this patient population is extremely multidisciplinary. You need a multidisciplinary team to look at these cases, the tumors, the histologies, the PD-L1, all the biomarkers have to be available. And then you have to have surgeons who are willing to work through chemoimmunotherapy and all of that. And the major risk is that something happens in between, the patient doesn't get potentially curative treatment of surgery. But luckily, I don't think those numbers have been very high, although again, more clarity regarding exactly why roughly 20% of patients never go to surgery in these studies is important. I don't know if what Tony thinks. Yeah.
Yes. I think the data that's been presented for the Checkmate 77T and other perioperative trials, not only in ESMO, but specifically in ESMO, I think are transforming the way we are treating patients with the stage 2-3B disease. Usually that was a very easy decision to make, because if the patient was candidate for surgery, the only discussion was, well, we can give the chemo pre or post-operative, but the net benefit will be low. I mean, we weren't transforming the lives of these patients. We know that most of these patients will relapse upon follow-up. So we were just waiting for most of them to relapse at some point. But now we are probably curing patients, because those who achieve a PCR, we're pretty sure that they are not going to relapse in the next years. So more than 90% of patients who achieve a PCR in a locally advanced disease are potentially cured. And this has been also presented in ESMO with the keynote. Sorry about that.
671?
679. Where for the 671, that for the very first time, there's been data on overall survival. That was a primary endpoint of the trial, not only EFS, but also OS. That means that this approach is really transforming the survival. And now we are discussing this patient in a multidisciplinary setting, and the more and more patients are getting chemo-IO preoperative. However, there will be small differences because at the end of the day, the evil is in the details. And at least in the European region, in EMA region, the neo-adjuvant nivolumab in combination with chemo is limited to those patients with PD-L1 positive expression, which doesn't make a lot of sense at all. We have patients with PD-L1 negative that achieve PCR and haven't relapsed. So this is a really transformative treatment.
So just to simplify things, so in early stage disease,
Yes.
is the consensus today in 2023, 2024 that all comers should undergo neoadjuvant therapy, or are there patients you would take to surgery right away? Tony, and then Haas.
Well, this is debatable. I don't think all patients has to be discussed for neoadjuvant chemo-IO. In our case, at least stage 3 disease that are potentially resectable, we trend to put these patients on chemo-IO perioperatively, 3 or 4 cycles and then surgery, but not all patients with stage 1B or 2 disease are discussing for chemo-IO, because sometimes these patients are operated before they are discussed because this is a nodule that cannot be achieved for biopsy by either bronchoscopy or a CT scan, but it's clearly a malignant tumor, and they get the surgery right away because there's no way to get the tissue before the surgery. So this patient is already operated, the tumor is gone, and then we'll discuss if that patient is adjuvant chemo or IO. But there are certainly some patients, specifically stage 1B and 2, that probably all of them don't go to chemo-IO, and there will be some patients that we can debate if chemo-IO is the best approach. But for stage 3, stage 3A or stage 3B, potentially resectable, this treatment option is a very new option that has to be discussed in every multidisciplinary tumor board.
Hans, do you agree?
I agree. I think stage 3, there's clear evidence from all of these studies that they can benefit from neoadjuvant and then an adjuvant approach. So in our tumor board discussion, most of the time we have uniform agreement that for a stage 3 patient that deemed to be surgically resectable up front is a good candidate. I think what I'd like to sort of say is that I think, at least in the US, this is a very different institution by institution, meaning there are places where everybody gets neoadjuvant regardless of the stage, and there are places where you discuss and you decide. So I agree with Tony that stage 1, maybe some of these patients don't really need neoadjuvant. There's not a lot of data. Stage 2 is debatable because there's a level of controversy. If you look at the hazard ratios from most of these studies, you can't say for sure stage 2 is uniformly benefiting. I think that's the reason why we need to have this multidisciplinary discussion regarding who really is a candidate and who's not.
Now, let's say you decide to give neoadjuvant therapy, then I want to move to locally advanced disease. You decide to do neoadjuvant therapy. Can you get by, Haas, with just immunotherapy alone? Do I need to add chemotherapy? Are there studies to show I can go by just with IO neoadjuvantly without adding chemo?
I think what we saw at ESMO was Mark Awad's presentation where you can use a combination of IO, because that was one arm of the, I think, Checkmate 816. That was not, it's not the arm that has had the sort of the statistical hypothesis built around it. But what Dr. Awad presented was this exploratory analysis population, about 110 or so patients who got ipi-nivo without any chemotherapy. And again, the outcomes were in terms of event-free survival in favor of ipi-nivo versus chemo alone. But, again, the caveats of the PD-L1 selection, no molecular markers, all of that has to be in place. I'm not aware of single agent IO studies I'm sure there are some institutions that have done it. And I think the best single agent IO study that sort of started this whole field is Patrick Ford's nivolumab study that basically was like 1 or 2 doses of Nivo, and then everybody, the 20 patients published in New England Journal of Medicine. But since then, everything has been chemo IO. I think some of that has to do with trial design, because some people consider chemotherapy alone as a appropriate control for neoadjuvant. So I think that's why IO was built on it. There are many thoracic oncologists who don't believe chemo is the only standard for neoadjuvant, but nonetheless, I think the study sort of developed along those lines. I don't know if Tony knows of any single agent IO besides Patrick Ford's study.
No.
Tony, go ahead. I was going to tell you, Tony, that in my mind, I always think of neoadjuvant therapy as a way to convert unresectable disease to resectable disease. But listening to you and Haas, there's actually it's more than that. There's actually there's an immunological effect. Like this is not just about surgery. In other words, you could still have resectable disease, but you still elect for neoadjuvant therapy because you're doing something to the tumor.
Right, but this is a very borderline indication. I don't think that most of the patients that were included in neoadjuvant trials were non-potential resectable. They were resectable upfront, or the decision was, well, surgery is possible after chemo, but the decision was upfront, not after neoadjuvant treatment. So I think that many people still think that we can convert unresectable disease in resectable disease based on response, but we are facing new challenges like the tumor staging with PET CT scan or mediastinoscopy or EVAs after neoadjuvant chemo IO is not really well established. We have seen patients that don't downstage clinically, but at the pathological level are under complete response. So it's not very easy to discriminate what patients are on PCR before surgery, because the tumor, the image in the CT scan is still there. Right. So if the decision was a right pneumonectomy and the patient still have a borderline pulmonary function, and the reason to do chemo is to avoid pneumonectomy and convert into lobectomy, but still there are gaps in the CT scan, then chemo is not the right approach. I think for those patients with really unresectable disease, we have a very good alternative, that is definitive chemoradiation followed by 1 year of adjuvant durvalumab. That is very consistent, very long-term overall survival results. So there's a very good option for these patients. We don't have any trial exploring to convert an unresectable stage 3 disease into resectable stage 3 disease. So we should avoid this kind of approaches, but of course, all these cases have to be discussed into multidisciplinary tumor boards.
Haas, before you go into subsequent data, because you guys need to tell me what's out there, there's one thing that just came to mind, and it's hard for me not to ask. As we, a lot of you now, you sequence these tumors and try to understand the genetic profile of these tumors. If you have, let's say, an ALK positive tumor, EGFR positive tumor, are there studies that are looking to do neoadjuvant therapy with an ALK inhibitor, with an EGFR inhibitor, and then you really don't need to do even chemo IO? I mean, maybe Haas and then Tony, you can address that, and then I want to move to additional data at ESMO.
Now, the short answer is that yes, there are studies looking at neoadjuvant targeted therapy, and there are examples of small studies using TKI already published, sort of suggesting that this approach could be beneficial. But there was one that was presented at ASCO where the pathologic complete responses were osimertinib, if I'm not mistaken, wasn't really all that good. So I think it's an area of sort of active investigation. We have to look into that data. But you're right, there is a need to develop these sorts of strategies in patients with targeted therapies. And under that category, you've touched upon the two that are more common, probably EGFR and ALK. I think it's going to be very difficult to do a large randomized study in patients with RET alterations or MET alterations or anything like that. But perhaps in the EGFR setting or ALK setting, this would be, doing a larger study would be a more feasible option.
Any comments, Tony, on that?
Right, we already have very good data in the adjuvant setting. So the important message here is that we have to molecular profile these tumors before surgery to avoid chemo-IO in these patients, because probably target therapy is the best approach. And we have two trials, the ADAURA trial with 3 years of osimertinib after surgery, and the ALINA trial with 2 years alectinib versus chemo that improves dramatically the DFS, also avoiding brain recurrence in these patients, that is a very, very common feature. So at least we have these very strong phase 3 trials that support the use of adjuvant TKIs. And of course, there are neoadjuvant trials trying to answer the question whether or not it's better to administer these TKI agents. But I don't think, honestly, that we will get the same results in terms of EFS that we have seen with limited chemo-IO approach in patients without tumor, without driver alterations, basically because there is a sense that the time of treatment is important for this patient. So probably 3 years of osimertinib is good, but nobody knows if 5 years is better than 3 years. And probably with alectinib, 2 years alectinib is happening the same. So a short treatment versus a long treatment may be a differential thing for these patients.
Us, next, what do you have for us? Additional data from ESMO. I don't know where you want to go. I think we did okay on the early stage disease. I think we'll go metastatic or locally advanced. Your call.
Well, I think there's one other study that's kind of important for us to talk about in the metastatic setting, and that's the TL01. This is datopotamab deruxtecan versus docetaxel. It's a long-awaited study. Datopotamab deruxtecan, or Dato-DXd, is the antibody-drug conjugate targeting TROP2. There's been a lot of interest in antibody-drug conjugates, and the results of this TROPION-Lung1 was presented at ESMO. So this is a randomized phase 3 ADC versus docetaxel. Again, a lot of good preliminary data for all of this. I think we all agree that this was done correctly. This was an area, and still is an area, of unmet need, meaning the patients with chemo, immunotherapy, after disease progression. Unfortunately, our options are very limited. We're back to cytotoxic chemotherapy with limited clinical efficacy and a lot of toxicity. So when the ADCs became popular, there was hope that we can replace them. And there are a number of these ADCs that are in phase 3 and are entering phase 3. So it's going to be a very crowded area. But as I said, the TROPION-Lung1 was one of the first to go into this space, so everybody was waiting for this result. So inclusion, exclusion was very standard. Everybody had chemoimmunotherapy, 1 to 2 lines of prior therapy, no other actionable mutation, simple randomization, ADC versus chemo, standard dose, just kind of a clean study. This is what you want to see. Ask one simple question, you get one simple answer, you sort of move on. And of course, it does open the door for additional information and additional research. The ESMO presentation included PFS only. I think OS might be a little bit premature. And in the presentation, there's a clear advantage to the ADC over chemo. When you look at PFS, the hazard ratio is 0.75. Numerically, there was a 4.5 months improvement in PFS for the ADC versus around 3.6 or so with chemo, docetaxel, which is really expected. Responses were higher in the ADC compared to doci, but the p-value was significant. So I think PFS is good. Subgroup analysis was presented. I think because of probably this is my idea, that because of the hype around ADCs, we were all hoping for a much better PFS and a much larger differential in terms of response and all of that, and we didn't really get that. Plus, the ADCs have proven to have toxicities that are legitimate, and we have to pay attention to them, even though many of them could be grade 1, 2. But to quote a patient advocate that we love and heard a lot, Joel Friedman, chronic grade 2 toxicities can be life-altering and affects your quality of life, really. So I think some of my colleagues and my discussions with them have been a little bit less impressed, but it is a positive study for PFS. The drug works a little bit better than docetaxel. The other complaint in the US side of the border, not in Europe, is that many physicians here consider doci-ram as the control and not doci alone, because the study is approved here. I mean, the doci-ram is approved in the US. I'm not sure how I feel about that, honestly, because again, in a global study, you don't have RAM everywhere. But that has been a criticism in the US that doci-ram was not an option. So I think at this one, we're going to wait and see what happens with the overall survival and sort of decide where this particular ADC sits. But more information is going to come.
Tony, any comments on this trial?
Sure. I think the trial was positive in terms of the primary endpoint. That the exploratory analysis that was very surprising for us was that the benefit was primarily driven by patients with non-squamous histology. We didn't expect that, and we don't know the real reason for that. Is because squamous are expressing less levels of TROP2, or is there any other biological explanation for that, or is just by chance? We don't really know, and we are starting to learn many things from this agent. So a small difference among these different ADCs may be important. This reminds me somehow to the history of pemetrexed that was primarily driven to non-small cell lung cancer, and then we learned that non-squamous histology was the primarily patients that benefit from pemetrexed, not squamous. This is a very similar story for that here, and we don't know how it's going to impact anti-regulatory agencies and how the physicians are going to adopt that. And I agree with Hoss, because specifically for non-squamous histology, there are physicians who support the use of docetaxel plus an anti-VEGF. We have here in Europe nintedanib that already have positive overall survival results in non-squamous histology, not only in PFS, but also in OS. So docetaxel may be insufficient or not all that we can provide to the patient. But of course, the benefit is still small when adding an nintedanib, and we also adding toxicity. So ideally, we would like to see a randomized trial in this histology versus docetaxel plus anti-angiogenic. But we are waiting for other ADCs in the same setting with similar mechanism of action, very similar trial designs, and we'll see in the next months what is going on. I think it will be interesting to positioning all these agents in the second line setting that is clearly an unmet need for us in the clinical oncology.
It's a great summary, and also it's great to see a new class of drugs really making its way into lung cancer. Okay, next.
Well, and then we go to targeted therapies. So here, Tony and I have to split. There were, at least in my view, 3 sort of interesting and possibly key studies. And they all have now I have learned, these are all butterfly names. There's Papillon, there's Mariposa, and Mariposa 2. Mariposa 2 is they couldn't come up with something more creative. It had to be Mariposa. I mean, I don't know. But so I'm going to hear from my friends there. So I thought the Papillon study could potentially be very, very helpful and could potentially practice changing. And I'll give my take, and Tony can say. So Papillon was basically a study conducted in patients with exon 20 insertion mutation. Definitely a rare mutation, but one that we see because we do so much molecular testing now. And this was a randomized study because the standard of care at the time of initial diagnosis for exon 20 insertion is usually chemotherapy. IO is not thought to be very effective here. So chemo has been the standard. In Papillon, the bispecific antibody amivantamab was added to chemotherapy to the experimental arm. So amivantamab chemo versus standard chemotherapy. Again, a well-conducted study. good rationale behind that, good toxicity profile for amivantamab. We know a lot about it because it's already been used in the refractory setting. And then you do a randomized study, standard drugs used in both good numbers, but 150 or so patients per group, and you sort of see what happens. So what basically happened is that the primary endpoint of the study, which was progression-free survival by sort of blinded independent review, was significantly better in the amivantamab plus chemo. But it has a ratio like almost like 0.3, like 0.3 and a half, something like that. And the median survival was also better, double digit, around 11 and a half months in the experimental arm. So this is a patient population for whom we really don't have a lot of options. So besides chemo, because this other oral agent, I'm not sure when I talk about it, that used to be used in the second, third line space, sort of went off the market because confirmatory studies were basically negative. So we were left with not having a lot of options. So now being able to improve outcomes in the front line is really important, but we're left with a little bit of a hole in the second, third line space, and I realize that. But given the fact that majority of our patients at the time of initial diagnosis are candidates for more aggressive therapy and tolerate more toxicities and all that, I think this is a good positive finding and one that can be practice changing if it gets regulatory approval. The toxicities were, again, very much as expected. Infusion reactions happen a lot in the first cycle with amivantamab. There's rash. There are issues like that, but no major surprises with the addition of chemo. So I thought this was a good study and one that, again, if I have access to right now, I can use it in my clinic.
Thoughts, Tony?
Right, I agree. It's a new standard of care for the very few patients that we see in the clinic because these are very rare.
What's the percent? Help the listeners. Like, how often do you see that the exon 20? Like, what's the percent?
Well, it's one of the most common uncommon mutations. Uncommon mutations are around 15% of EGFR mutations, and overall exon 20 mutations are around 4 to 5% of all carcinoma with EGFR mutation. So not a very huge population, but very important in terms of finding them. And very important, these mutations are not easy to find because most of commercial PCR hotspot tests don't detect most of these mutations. They detect some of these mutations, but not all of these mutations. And the current recommendation by most of the guidelines is to perform NGS, to be able to detect all of these mutations. So now that we have a new treatment that we can offer for these patients, it's very important to detect all these candidates as soon as possible. And I think that in the first line setting, amivantamab performed very well, better than expected. And again, I think they surpasses all the oral TKAs that went from very long way to get the point in the first line setting, but amivantamab did before. And I think we have to learn again about the side effects. These are new agents, the B-specific are new agents, and we have to accommodate our daycare visits to these infusional treatments, infusional reactions, side effects. That is a matter of experience. Once you have the learning curve, you know how to deal with these agents. So at least for this population, is clearly to me a new standard of care. So Papillon did a very good job.
That's great. Okay, the next butterfly or something, Mariposa, whatever that is.
Tony, you want to take Mariposa?
Right. This is one of the most exciting trials in the year because again, an chemo-free option beat osimertinib, that is currently the standard of care. And there seems like a plateau in the treatment of common mutation with osimertinib. We have to add in something on top of osimertinib to improve the outcomes, and amivantamab did it. This is a large randomized phase 3 clinical trials. They include common mutation, that is the exon 19 deletion and the exon 21 mutation, .1 mutation, patients with good performance status. And importantly here, patients were screened with a brain MRI. And that's very important because this detects an asymptomatic brain metastasis, and also you can calculate well the intracranial response rate and the intracranial PFS, what is of utmost importance in these patients. The trial had 3 arms. Patients were randomized to 3 arms. One was osimertinib, the standard of care, and the control arm, and the experimental arm was amivantamab, that is a B-specific anti-EGFR and MET antibody, plus lazertinib, that is a new third-generation EGFR TKI. To control the effect of lazertinib, a third arm was included in the trial, that is lazertinib monotherapy, to compare the performance in terms of PFS and side effects against osimertinib. The primary endpoint was PFS, and basically the trial performed well with a median PFS of almost 2 years, 24 months, with the combination of lazertinib amivantamab, which is very remarkable. Osimertinib usually is around 18 months of PFS. In this trial was a little bit shorter, 16 point something, but the hazard ratio was good, hazard ratio of 0.70. So the trial was positive. And also it was positive in patients with and without brain metastasis. So this agent has brain activity, which is very important in this population. The data on overall survival is still immature, and we don't have, I mean, the preliminary figure seems encouraging, but we cannot say nothing at all at this point. The question with this combination was the toxicity profile. I think this is something to discuss because we are adding efficacy, but also toxicity. Of importance, the combination of a TKI plus amivantamab increased the rate of thrombotic events. Mandatory prophylactic coagulation is needed for this patient. So you have to discuss this with the patient. Then you have the infusional reaction that usually happens in the first 1 or 2 infusions, then when the patient has no IRR later on, and skin toxicity and diarrhea and edema, that is a MET-specific toxicity together with hypoalbuminemia. So something to discuss. This will be long-term toxicity, probably grade 1 or 2, but again, this is toxicity that can be burdensome for the patients. The discontinuation rate was high in the trial. At some point, patients, 2/3 of the patients basically had to stop one of the 2 agents because of toxicity, compared to 10%, around 10% in the control arm. But overall, it's a new treatment option that met its primary endpoint, and now we have another opportunity to treat patients in combination with a chemo-free intervention for these patients.
Haas, any additional comments to what Tony thought? Because there's another Mariposa, you said there's like a Mariposa 2. So
Yeah.
maybe any comments on what Tony said, and then we move to the next trial.
No, not much else to add. I think he covered pretty much. Mariposa 2 was using the same combination amivantamab chemo with or without the lazertinib that we just talked about, but versus chemotherapy in patients that had actually had evidence of progression on osimertinib. So it's slightly different. So second line, basically, after osimertinib. Again, that's an area where we don't really know what to do with patients. Some of us do chemotherapy. Some people do the Empire 150 with the quadruple carbopaclitaxel bev type of a thing. So an area of unmet need, and there are studies that want to look at this. Mariposa 2 then took amivantamab, lazertinib chemotherapy was one arm, chemo was the control arm, and the other experimental arm was simply amivantamab plus chemotherapy. Again, everybody had prior osimertinib. They then sort of revised and amended the study. It ended up being a 2-arm study with amivantamab, lazertinib chemo versus ami chemo. Again, the study clearly shows that either of the 2 experimental arms are much better than chemotherapy. So you sort of already have some idea, some sense as to what you want to do. The hazard ratios were very close to each other. Again, pretty impressive, 0.48, 0.44, so to speak, when it comes to the progression-free survival kit, because that was the primary endpoint. So you have a pick of choosing the 3-drug right now, in my view, or the 2-drug. I don't know how Tony feels about this, but I'm a little bit more worried about the toxicity with lazertinib added to the amivantamab and chemotherapy. I think if I can have very similar responses, very similar PFS with amivantamab chemo, do I really need to bring the lazertinib into this? And again, additional cost, additional potential toxicity. So for me, if this becomes an option, I think I would prefer just the amivantamab chemo. Now, granted, this was just our first look at this. We haven't seen the actual manuscript with more details, just the presentation. So there's a lot of information that's still missing. But based on the presentation, again, I would say amivantamab chemotherapy is an option for some of our patients post-progression on osimertinib.
That's excellent.
Yeah. Completely agree. I think that amivantamab has a lot of sense in this indication. It's an agnostic approach. You don't need to know what's the mechanism of acquired resistance to osimertinib. That avoids you to biopsy these patients, either tissue or liquid. So it theoretically works irrespectively of the mechanism of resistance, which is a nice approach for the general practitioner. And I also agree, I think amivantamab on top of chemo is probably the way to go. We don't need probably lazertinib here. It's increasing the thrombotic events in this setting. You are adding toxicity, but you are gaining something here. PFS is important. Yeah. We don't have data and overall survival, but I think it's something meaningful, and in this indication, it has a lot of sense.
So we've got 5 minutes or so to go over whatever rapid fire you guys have. So like briefly in the last 5-6 minutes, what else should we cover? Tony?
Well, I think the jewel of the crown is in target therapy, selpercatinib.
Let's hear it.
Yeah. So selpercatinib is a next generation RET inhibitor with brain activity. It's already approved in previously treated patients with RET fusion non-small cell lung cancer. During ESMO, they present the results of the randomized phase 3 clinical trial in the first-line setting of selpercatinib versus chemo or chemo-IO, chemo plus pembrolizumab, in patients with RET fusion non-small cell lung cancer. The trial design was very simple. Patients with performance status of 2 or 0 or 2 with metastatic non-small cell lung cancer and RET positive by NGS or by sequencing methods were randomized to selpercatinib, an oral pill, versus chemo or chemo-IO upon physician discretion. The primary endpoint was progression-free survival, and the results were impressive. The hazard ratio was 0.5, with a median PFS of 25 months for selpercatinib compared to chemotherapy that was 11.2 months, which is still quite remarkable for chemotherapy or chemoimmunotherapy in this population. Selpercatinib also had activity in patients with baseline brain metastasis, but also prevent the progression into the brain. So the rate of intracranial progression was very low, near to 0. The quality of life was better for patients with selpercatinib compared to control arm, and the rate of side effects was more favorable to selpercatinib with a known safety profile, and now is the standard of care for this population. If it wasn't already with the data of the phase 1 trial, but now regulatory agencies, especially in Europe, has a reason to approve this agent in the first line.
Yeah, and because you have limited time, I'm just going to say, in my view, the Alina study was also quite significant. So that was using alectinib in a post-surgical setting. Ben Solomon did a great presentation. And basically using alectinib post-surgery was associated with a significant improvement in disease-free survival in patients with resectable positive disease. The only criticism is that the control arm was chemo, but the experimental arm did not include adjuvant chemo, and many of us still think adjuvant chemo can offer survival advantage even in this patient population. But the results, again, hazard ratio 0.2 or something to that effect in terms of disease-free survival. So I thought that was also a very significant study. And again, we're going to hear a lot more about it.
So the design was different than ADAURA. ADAURA already got chemotherapy and then randomization to OC versus placebo. This one, basically alectinib versus chemotherapy. I actually like the ALINA trial design. I mean, hey, just lose the chemo.
Yeah. Well, on ADAURA, you had the option of using adjuvant chemo or not. So some patients got adjuvant and some didn't. But in the final analysis, it didn't seem to matter if they got the targeted therapy. So again, this has led to a lot of discussion among us thoracic oncologists. Do we need adjuvant chemo or not for patients with EGFR or ALK positive? And that's going to be debated because I don't think we're going to have those studies anymore.
Do you think we covered the most important stuff? I know there's like thousands of abstracts. Believe me, I know that. I always tell my listeners, we're going to try to cover things that we really think have the most clinical impact.
This is the practice-changing abstracts. Those that change the day after they presented the data. So I think we are not missing any important abstract. I think we cover all the very important ones.
Well, my two guests, the two first-timers on the Healthcare Unfiltered, Dr. Tony Calles and Dr. Borghaei, or V. Hoss. Thank you so much for spending time really on today's podcast. We're taping this before the holidays, so I hope you have an amazing holiday season. And I can't thank you enough. These are the type of podcasts where we talk about clinical advances, where really we get a lot of listeners who are very grateful because they get to know the nuggets of these meetings and apply this to their practices.
Thank you so much for the opportunity. Happy holidays to everybody.
Thank you very much, and happy holidays to all of you.